So what's the solution? I will start with the solution. So the solution is about, it's all about the money. Okay, so for anything, you need to have the resources, you need to have the funding. So a blind child is everyone's responsibility and liability. Obviously, you know the socio-economic impact of having a blind child. So it cannot earn on its own in future. We need to take care of the education. The child has to be for the family, for the community, for the country as a whole. This is going to be a huge financial liability. So the kind of money that you're going to invest in trying to take care of this blindness makes a lot of sense. Makes a lot of sense. So we are trying to put in a lot of money into adult or geriatric blindness, somebody who's 80, 90 years old. We are doing cataract surgery. We're putting a lot of money into that. Probably the number of his blindness years, in case we don't do that, will be far less compared to a child whose blindness years can be really astounding. So we have uh, children like this who are attending schools today. So we have refractive errors, we have squint blindness, which is basically a unilateral blindness, but still has been pushed to the corner because it doesn't really make any sense to most people because the child is still seeing and attending school. And corneal blindness still is lurking, is one of the very important major problems because of its technical difficulties in the managing corneal blindness. So basically it's a very resource intensive specialty, and the biggest problem is the cash crunch. So the effect, there are, even though there are programs, there's a very poor implementation. So who are the stakeholders? It's basically the family. Okay, for many reasons like social reasons, economic reasons and myths, and they don't have an access to pediatric care. So many a times they may not be able to discharge their duty, but obviously the health system has to chip in and try to bridge the gap and try to cross over these hurdles of socio-economic problems. So obviously we do need to, have some kind of points of contact. Anganwadi is one very important area, probably where, because the child is still in a very young age where the child's so-called blindness can result in a permanent scar, can result in a permanent visual disability. So this will be one important area wherein effective implementation of our programs can leave a much better impact. And the primary health center obviously still has to be sensitized, that staff can be, they really can do a good job in a proper referrals. Now we have this whole army of ASHA workers who actually are doing very good job in some of the states. At least in Karnataka, we have a very good experience with ASHA workers. The school teachers have been always, Dr. Parikshit has alluded to it, one of the very important weapon in our armamentarium where we can use them very effectively, because the parents are, many a times they do listen to the teachers, especially in the rural setting. So the school work teachers has to be sensitized, and the vision center technicians, the pediatrician, of course, for both in the rural urban setting, the immunization staff, and all these actually. But where are the money coming from? Basically, we have some of the international NGOs like Orbis, which has been really focusing on very aptly the childhood blindness as a focus area. And we have the government set up, both the central and the state government. But even though the kind of allocation to the overall health in most of our budgets is very abysmal, but the amount of coming to probably eye care is still less, and to pediatric eye care probably is very disappointing most times. And we have the CSR funding, and we have the private sector also chips in. So these are all the different areas in which probably we do have the resources. But the whole important hurdle is being that there is no mandated screening that still that doesn't really find a place even today. So unless we really make it mandatory, as we are talking about the preschool placement, like before the child enters the school, if there's a mandatory eye screening, then that can probably screen a lot of things, refractive errors, squints, and other problems, amblyopia. Similarly, at the Anganwadi, if there's a mandated screening, annual screening, that probably can be a very easy to for case finding. And basically each state has probably their own populist programs. Many times they don't reach the logical end. Most of them will be actually a new government comes and they will roll out a different scheme altogether, try to alter the existing scheme, and sometimes they collate many schemes into a different name. So there are multiple names. In fact, there are so many schemes at least in Karnataka, so many of the officials actually do not know any details of that. Like when we went to like to the neighboring district of Karwar and asked for a Bala Sanjeevani scheme. Okay, they really had to dust out a lot of papers and uh, take things out from where they took really 3 days to really find out what that scheme is all about. Even though it was supposed to be, they must be running that scheme, they really had no idea, no clue about are there any funds under these particular scheme that even the government has actually rolled out. And many times the government rolls it out, but it doesn't really go till the field level. So basically, if you have you need to probably different allocation for different diseases, different problems. But what is ideal is a national policy which integrates all the stakeholders. So we are actually many times reinventing the wheel, duplicating our services and our policies. So if we can make childhood blindness a priority area, as I told you, for obvious reasons that we are converting a curable blindness into an incurable blindness just by the delay, and also in terms of its economics, probably that is the best return on investment on eye care is in pediatric area. And obviously we need to have some kind of an adoption by different institutions, because we have so many institutions of repute in India. If they can actually adopt a particular geographical area, then probably we can have some kind of an equity with quality. The whole problem in pediatric eye care is equity, because a lot of areas are unserved or underserved, and there are also issues of quality. And we need to really look at which are the areas which have very higher prevalence. So we should have a childhood blindness component in every program and trying to cover. And basically I told you the continuity of care, because we need a strict follow-up, we need a lot of ancillary support from various departments. So basically if we can integrate all this, we can actually have, that is the basic challenge. There are a lot of skip areas, and different aspects of childhood blindness have to be tackled differently. So we have discussed all these by the previous speakers, and well, this is something which very close to my heart, and many of the people working in this community pediatric ophthalmology have found a lot of help from Sarva Shiksha Abhiyan. But this is something which most people, it has been one of the underutilized or underexploited scheme by most areas. And also there is some kind of an apathy in some states about the proper implementation, even though they have an excellent network of officials and field level workers. There is a parallel system, just like we teach. The Department of Public Instruction or Department of Education or Human Resource basically takes care of teaching the children. There's an entire network of people who are dedicated to Sarva Shiksha Abhiyan implementation. Of course, the kind of effectivity of these programs being implemented in different states do vary. Okay, there are a lot of states which actually do very well with the Sarva Shiksha Abhiyan, but this program is something which has given excellent results by, well, basically when they join hands with some of the NGOs, some of the private organizations. So this is one of the very good example of a public-private partnership, because the NGOs have the commitment, have the expertise, and have the know-how of how the field works. At the same time, this government system has the teachers under them, they have resource persons under them, and the school and the basically the Anganwadis, okay, can be very effectively brought under this particular screening programs. So only thing is we need to probably avoid the duplication. Many people doing the same job, and this is the potential. But anyway, as I told you, like everything keeps changing in our country. There is an effort to unify all the schemes, the different schemes for different levels. So there is a universal health care is, I mean, rather that is the probably which is arising in the horizon, and probably such a thing has both advantages and disadvantages. Probably if you unify too many things, then the actual focus on childhood blindness can actually evaporate and can become less important. But at the same time, if we can probably unify all the scheme, that there can be a better integration of stakeholders, so that a better implementation can happen. And this RBSK, of course, this scheme nowhere works in most of the states now. Rashtriya Bima Swasthya. This is Karyakram. This is which also had an element of pediatric thing, because they were actually getting some amount of financial help for treating children even. So We need to basically see that the resources which are coming into pediatric ophthalmology in at the community level need to integrate, and basically it has to all the stakeholders have to prioritize childhood blindness so that more money can flow into these areas, and we'll still need very clear guidelines, like and we need to basically convince the policy makers about keeping the childhood blindness, because which is probably the best return on investment. I think, as I always told you, of all the probably the most satisfying thing in our whole ophthalmic practice or life is trying to restore a smile on a child's face. Thank you very much.